Now we will have the welcome address by our President, Dr. L. Murugan sir.
Good evening. A warm welcome to all of you from TANS. Thanks Dr. Govalan for being the observer from TamilNadu Medical Council for enabling the CME credit. Good evening and a warm welcome to all of you from TANS. Thanks to Dr. Govalan for being here as observer from TamilNadu Medical Council for enabling the CME credit points. Thanks to all the speakers and moderators for being present here to present their topics and discuss the topics in detail. Special thanks to Dr. Rajesh Babu, our TANS secretary, who organizes all the CMEs and various other programs for TANS. Over to Dr. Rajesh Babu, TANS secretary, for the secretary's report. Thank you and hope all of you enjoy this program.
Good evening, everyone. I welcome you all for today's TANS CME program, which is the topic is the Trigeminal Neuralgia. I welcome you all for this program, and I like to thank our Tamil Nadu Medical Council observer, Dr. M. Govalan sir, who has been the observer. He was invited only at the last minute by the Tamil Nadu Medical Council and us also. I welcome you, Dr. Govalan sir, for the nice program. So I request Dr. Suresh Jayagolan sir to tell a few words about the program and felicitate us.
Thank you, Dr. Rajesh Babu. Welcome all the delegates. I welcome the speakers and Dr. N.Sridevi madam, who has organized this meeting, and Dr. Devi madam, and Dr. Swarna, Rekha, and the moderators, Dr. Vijaya madam and Dr. Percutaneous madam. I think it's going to be a wonderful program, Trigeminal Neuralgia. We are going to cover from medical management and percutaneous as well as the surgical management. It's a common disease, everybody knows. Here, mostly the non-neurosurgical, neurological people are also attending this workshop-like thing. I think everybody will come to know what it is, and there is a treatment option, variable treatment option is there, and I think everybody should know so that the beneficiary will be our patients. I think it's a very good organized and spearheaded by our dynamic secretary, Dr. Rajesh Babu. Thank you very much. I think we go ahead with the program as scheduled.
Now I request Dr. Govalan sir to tell a few words. Yes, sir.
First, I thank Tamil Nadu Medical Council for sending me as an observer to this program. I know Dr. Rajesh Babu sir is very efficient organizer of all the program. I'm very happy to be here. I will stay here till the end, and like you also, I also benefited by this program. In future programs also, I will participate as an observer from Tamil Nadu Medical Council for all your work. Thank you for inviting me, sir, for this program. I am very happy. Thank you, sir.
I request Dr. Pandirajan Kumar to tell a few words about Dr. Pandirajan sir.
Tamil Nadu Association of Neurological Surgeon and Indian Medical Association Tirupur branch cordially invite you to the online CME program with Tamil Nadu Medical Council approval of 1 credit hours. I am Dr. Pandirajan, an Indian Medical Association Tirupur branch president. Hereby welcome to all speakers and moderators and our Tirupur branch office bearers and our beloved Arul Jyoti CME coordinator and beloved participant of CME program. Let us start the program. Dr. Arul Jyoti is going to coordinate the program. Thank you all. Happy New Year. Happy Pongal wishes to all our beloved senior doctors and friends. Thank you, sir.
Thank you so much, sir. Now, today we are having this nice CME program where our moderators are Dr. Vijaya madam and Dr. Pritikachari madam, our senior professor, neurology and neurosurgery,
Okay, sir.
going to moderate this program, and I request both of them to kindly take over the session and continue the program.
Okay.
Thank you very much for inviting me and all others. It was a very nice program and very, very useful to everybody. I just want to put a few historical notes. One is to say that 1773, John Fothergill recognized that in the Medical Society of London, he presented a paper which said on a painful application of the face, but he didn't put the name there. But 1829, Charles Bell, he is the one who distinguished both trigeminal and facial pain. It was 1934. Walter Dandy, he was doing a lot of suboccipital venectomies. At that, he used to do a retrogastrian trigeminal neurotomies. But he made the observation that there is a blood vessel which is impinging on the trigeminal nerve, which might be more responsible for this kind of pain. But it was left to Peter Janetta, who popularized the microvascular decompression. Okay, we have come to microvascular decompression, and beyond that, so many other modalities of treatments. But I just want to go back to 1980s in the institute, where we used to still prescribe only medicine as well as pens, peripheral neurectomies, and very rarely we used to do glycerol injections. So you can imagine how it evolved through that. At that time, nobody was doing MVD in institute. Later, it became the norm. And to ask the speakers, Dr. Preetika would like to say something about this.
Yeah. Thank you, first and foremost, for inviting me to be a moderator in today's session. It's a real honor and privilege to be here. And it's also very nice to meet so many of you whom I don't get to meet very often. I just want to add to the history which Vijayas already pointed out, that way back in the 1858 or around that time, his name was Conahan. And what he was doing was he was actually doing a craniotomy, going inside and resecting the trigeminal ganglion itself. And he was producing some degree of relief. But even he has made an observation in a paper, in one paper, where he says it's very strange, but it's always there's a blood vessel which is very close to the nerve. In Walter Dandy, he was doing selective neurectomies, and he was also saying it comes in the way in the surgical field. Then later on, he found that when it did come in the way, and those patients seemed to do better. So it was actually serendipitous discovery that this vascular compression could be one of the etiological aspects for trigeminal neuralgia. Also, from the medical management point of view, we used to have no drugs first, then we had carbamazepine. And to this day, carbamazepine is still a very basic medication that we use. But we have a host of other drugs today, which gives us a choice because some of the patients don't tolerate carbamazepine. And we have the drugs like pregabalin, etc. I'm going to leave it to the speakers to highlight all those. But the microvascular decompression is still the treatment of choice. And any number of us who have seen patients who've undergone this will vouch for the efficacy of this treatment. Even after 12 years of pain, 10 years of pain, they get total relief. And this recurrence rate also is very low after microvascular decompression as compared to all other procedures. With this, I am truly grateful for this opportunity, and I request the first speaker, I don't have that chart with me, and maybe we should let Dr. Sridevi take over because she organized everything. And you call the shots from now on, Sridevi, and tell us who is speaking on what and take over. Thank you.
Dr. K.Aruna Devi is the first speaker. Dr. Aruna Devi is a MBBS from Coimbatore Medical College, General Medicine from Sri Ramakrishna Hospital, Coimbatore, and DM Neurology from Stanley Medical College, Chennai. She's 10 years plus experience in the field of neurology, now working at Sri Ramakrishna Hospital's special interests include stroke and epilepsy. I invite her to present her paper on medical management of trigeminal neuralgia.
Good evening all. Thank you for the opportunity given by the TamilNadu Association of Neurosurgeons for this very common topic. As we all come across in our day-to-day practice, most of both neurologists and I suppose even neurosurgeons, we come and see a lot of headaches. Probably headaches are the most common presentation or clinical syndrome that we see regularly in your clinical practice. So, though most of the headaches that we see are related to migraine or tension type headaches, we do most of the time come across trigeminal neuralgia in our day-to-day practice. At least 1 or 2 patients of trigeminal neuralgia we do come across. And since these are the most severe causes of headache, it is very important to know and treat these patients both medically and surgically. Coming to the anatomy, I don't think so this is much needed. We all know that the anatomy of trigeminal nerve starts from the pons, and there are nearly 4 nucleus of the involving the trigeminal nerve, which the most common one is the mesencephalic nucleus of the pons, the motor nucleus, the main sensory nucleus, and the spinal nucleus, which sometimes goes up to the C7 level. And these are the trigeminal branches of the trigeminal nerve, the mandibular, maxillary, and the ophthalmic divisions. And we know all these come from the Gesserian ganglion. And the ophthalmic branch supplies these areas, including cornea, ciliary body, conjunctiva, nasal cavity, sinuses, and skin of the eyebrows, forehead, and nose. And maxillary branch supplies the sides of the nose, lower eyelid, and the upper lip. And the mandibular branch supplies the temporal, the ear, the lower face, lip, oral mucosa, the anterior 2/3 of the tongue, and the mandibular gums and the teeth. So the motor branch of the mandibular nerve supplies the masseter temporalis and the pterygoid muscles. So this the trigeminal neuralgia usually occurs most commonly the V3 division of the division, and this is that which we come across very commonly. Though we do come across V1 and V2, V3 division is the most common division that is affected by the in this trigeminal neuralgia. So we don't have statistics from our side. So it is annual incidence is 4 to 5 patients per 1 lakh population. This as per US data, and the highest incidence is around 50 to 70 years. And 2% of multiple sclerosis patients complain of trigeminal neuralgia. Roughly in US they have around 15,000 new cases, and they are sporadic. And 90% of cases occur after the age of 40, and these are more prevalent in women than in men. And more than 70% of patients with trigeminal neuralgia are over 50 years of age at presentation. If they are less than 50 years, we need to consider other causes of trigeminal neuralgia. And what are the clinical presentation and classification? The clinical presentation, as we all know, it's pain. And the pain will be paroxysmal, and they attack when they occur in very, there will be several attacks per day, and they'll be stabbing or shock-like, and they'll be very severe. It is usually, we call it lancinating pain or electric shock-like pain, which occurs for less than 5 to 10 seconds. And pain provokes brief muscle spasm of the facial muscle that produces the so-called tic, which is probably the reason for tic Dolorox. And various triggers, these are the most common trigger points that can precipitate the attack. Even the light touch or vibration could even also be provocative. And patients also complain like activities like shaving, laughing, brushing face, washing of the face, eating, talking. All these can be a provocative factors for the pain. And these are the trigger points that usually patients complain about. And just giving one clinical scenario, a 38-year-old lady, this is a lady less than 50 years of age, who presented with recurrent bones of left paroxysmal facial pain, which had lasted for a few seconds, provoked by brushing the teeth, eating, and even talking. Her examination was normal, and the MRI showed this. This is more suggestive of a multiple sclerosis related trigeminal neuralgia. All these plaque, periventricular and brainstem plaque, these are more suggestive of a multiple sclerosis related trigeminal neuralgic pain. Since the patient coming to the physical examination, when we do a physical examination to try and find possible signs, that we will usually not have any signs, and patients will not allow us to touch while examining. And the only thing that we need to see is to see for the corneal reflex. If the corneal reflex is present, maybe it means that the clinical signs corneal reflex is normal. Then there is no other reason. Probably it's an idiopathic cause of trigeminal neuralgia, or probably it is the routine trigeminal neuralgia. When we have an absent corneal reflex, we need to consider a trigeminal neuropathy as a cause, meaning that there is some obvious compression and we need to rule out secondary causes of trigeminal neuralgia. So corneal reflex here plays a very important role in finding out whether it could be a idiopathic or neurovascular conflict related trigeminal neuralgia, or some schwannomas related trigeminal neuropathy. So what are the red flags when we come to the history of trigeminal neuralgia? When the age is younger than 40 years, when the patient has bilateral symptoms, when the patient has associated swallowing difficulties, when there's a dizziness or a vertigo, which could be, which points out to a central cause, when there's a hearing loss or any other abnormality pertaining to the ENT, and when there is some numbness, when we have numbness like corneal reflex absent, or when we have numbness in V1, V2 or V3 division, and when there is some pain which is outside the distribution of the trigeminal nerve, and there are some visual changes. If any of these red flags are present, we need to consider other causes of probably contributing to trigeminal neuralgia. And these are history related. And when coming to the examination, when we have some abnormal neurological examination, including corneal reflex, when there is an oral, dental or ENT examination which shows abnormality, when there is a loss of corneal reflex, when there is any jaw or facial weakness, or when there is paresthesia or dysesthesia of the face, or when there is a permanent area of numbness, we need to worry, and we need to be aware that we need imaging in this situation. Most of the time, trigeminal neuralgia will be a clinical diagnosis. Only when these red flag signs or symptoms are present, we need to go or ask for an MRI imaging to find out if there is any other associated cause. So what is the diagnostic criteria? There must be at least 3 attacks of unilateral facial pain and occurring in the trigeminal distribution without radiation, and should have at least 3 of the 4 characteristics listed below. That is lasting for maximum of 2 minutes. It should be very severe in intensity, and the pain should be electric shock like shooting or sharp, and precipitated by innocuous stimuli on the affected side of the face. And there should not be any clinically evident neurological deficit, and there should not be any other cause of headache. This is the diagnostic criteria. And when we go to the symptomatic trigeminal neuralgia, that is when we have some other cause, and in that the diagnostic criteria includes paroxysmal attacks of pain lasting for a fraction or for a second or 2 minutes without persistence of aching between paroxysms and affecting one or more divisions of the trigeminal nerve. And pain have the following characteristics, including intensity, when it is intense, sharp, or superficial or stabbing precipitated by the trigger. And when these attacks are stereotypical, when the patient feels that the attacks are always the same and stereotypical, and when there is a causative lesion other than neurovascular conflict, that could be demonstrated by the investigation like MRI. In that case, we call it as a symptomatic trigeminal neuralgia. So what are the causes of symptomatic trigeminal neuralgia? Meaning probably the other causes which can contribute to a trigeminal pain. These include cavernous sinus syndrome, cerebral aneurysms, cluster headache, hemifacial spasms, hydrocephalus, intracranial bleeds, migraine, multiple sclerosis, post-herpetic neuralgia, and subarachnoid hemorrhage. These are the causes of symptomatic trigeminal neuralgia. Coming to another typical case, a 53-year-old lady presents with continuous facial pain involving the whole side of the face. With her neurological examination, I would not say it is continuous. It should have been a lancinating pain. And then with a normal neurological examination, this shows a simple trigeminal nerve being compressed by a vessel. This will be the clinical picture and a MRI finding of a routine trigeminal neuralgia. And clinical picture, the distribution is usually unilateral. This is another imaging. And the pathophysiology is, it could be because of the demyelinated sensory neurons resulting in hyperexcitability, or it could be because of a neuron-to-neuron cross-excitation due to eroded insulation. And it could be an emphatic transmission and crossed after discharge between the non-nociceptive afferents and the nociceptive afferents that can cause and trigger the paroxysmal pain. So just this will be a routine history of a trigeminal neuralgic patient. In this case, should we ask for an MRI? Yes, when there is recurrent bouts, though in this scenario, we may not ask for a MRI brain immediately when the examination is normal. Nowadays, it is prudent that we ask for imaging to rule out other causes of trigeminal neuralgia. So neurovascular conflict plays an important role in primary trigeminal neuralgia, but demonstration of a neurovascular contact alone should not be used to confirm the diagnosis of trigeminal neuralgia, because even without the presence of neurovascular conflict, we do come to a conclusion of trigeminal neuralgia. It just helps us to decide if the patient will be will benefit from microvascular decompression. If MRI is not possible, we can use the nerve conduction to do the to find out. So coming to the differential diagnosis. So these are the other differential diagnoses that can occur around the face to come for a differential diagnosis of trigeminal pain. Headache associated with optic neuritis, and a headache associated with ischemic ocular motor palsy, and other causes of trigeminal neuralgia, as we told, like trigeminal autonomic cephalalgias, painful trigeminal neuropathy due to acute herpes zoster, painful trigeminal neuropathy associated with post-herpetic neuralgia, painful trigeminal neuropathy which could be post-traumatic, painful trigeminal neuropathy attributed to some space of pain lesion, persistent idiopathic facial pain, and burning mouth syndrome. And when nervous intermediate neuralgia of the facial nerve can also mimic trigeminal pain, but a proper history and will be helpful for us to differentiate between the both. And glossopharyngeal neuralgia is also a differential diagnosis and an occipital neuralgia. And central trigeminal pain secondary to multiple sclerosis can also present like a idiopathic primary trigeminal neuralgia. So what are the differential diagnoses? Trigeminal neuralgia, the differentials include cluster headache, migraine. And in cluster headache, the onset is usually around 30 to 40 years, and it is usually unilateral like trigeminal, but they will have most of the time associated autonomic symptoms like horners, conjunctival injection, and lacrimation. And the duration of the attack will not be in seconds. It will be around 15 to, it can persist up to 3 hours. And it usually clusters. It doesn't continue. It usually clusters between weeks or months. And usually nocturnal or 1 hour after sleep. And we will be knowing it is an alarm headache. The patient will usually be able to predict the onset of this cluster headache. And migraine is also a close differential diagnosis, but it is usually associated with photophobia and phonophobia. And atypical facial pain is another common differential diagnosis of trigeminal neuralgia. But the main difference is the duration. It persists for hours to days. And in atypical facial pain, patient can also have sensory abnormalities. And the intensity of pain will not be as severe as in trigeminal neuralgia. The atypical facial pain will be only mild to moderate in severity. And the other close differentials include glossopharyngeal neuralgia. Even glossopharyngeal neuralgia will be very paroxysmal, but it is usually triggered by swallowing or coughing, and not like touch or vibration, which usually triggers trigeminal neuralgia. And cluster headache, as we told, the cluster headache is also a close diagnosis, but the duration is little very long, and it will be associated with autonomic features. And chronic paroxysmal hemicrania is also a very close diagnosis. Even this will be associated with ipsilateral conjunctival injection or congestion, and autonomic features will also be there. But the duration will also be prolonged in this. And this is also another type of SUNCT is also another type of autonomic phalalgia. It also persists for more than the duration is not as long as in chronic paroxysmal hemicrania. It will be shorter, but not as short as trigeminal neuralgia. This will persist for less than 3 minutes, and the pain will be very sharp and associated with autonomic features. And Tolosa-Hunt syndrome. Tolosa-Hunt syndrome is a retroorbital pain, and this is a constant pain, will be present throughout the day, and we will find out some cranial nerve involvement like third, fourth cranial associated, third and fourth cranial nerve involvement along with ptosis in Tolosa-Hunt syndrome. And the treatment for all these, for glossopharyngeal neuralgia, is the carbamazepine medical management as we do for trigeminal neuralgia. For cluster, 100% oxygen, prednisolone is the most common treatment used. And these hemicranias respond better to indomethacin. And for SUNCT, corticosteroids and anti-epileptics like carbamazepine are useful. And Tolosa-Hunt syndrome, we need to find out if there is any other cause of Tolosa-Hunt, and the treatment is usually corticosteroids. And the next one is the herpes zoster involving the trigeminal ganglion. And for this, the treatment involves antivirals and steroids. And I don't think so we will be having difficulty in diagnosing herpes zoster related trigeminal neuralgia because of the vesicular eruptions. But this pain of herpes can come even prior to the vesicular eruptions. At that time, it will almost be like a V2 neuralgia, and only after 2 to 3 days of that very severe pain, patients will start getting these vesicular eruptions. And we need to think about herpes zoster if the pain is continuous in the V2 division. Going to the pharmacological treatment, as we all know, carbamazepine is the most common and most effective drug of choice for trigeminal neuralgia, and we usually start at a dose of 100 milligrams twice a day, and we usually go up to 200 milligrams thrice a day, and the highest dose that we can offer to the patient is around 1000 milligram per day. Though we don't cross around 800 milligrams, and most of the patients too don't tolerate carbamazepine at a higher dose. We usually use around 200 to 300 milligrams, either TDS or BD. Most of the time, the patients, they present with adverse effects to us. Most of the time, we see drowsiness, we see toxic epidermal necrolysis, Steven Johnson's, and nowadays I think we see more of hyponatremia present following this carbamazepine or oxcarbazepine intake. So we need to be very careful about this, and sometimes it can also cause AV block and hepatotoxicity. When starting on carbamazepine, we need to be watchful on what other drugs patient is on, and especially when patient is on beta blockers or calcium channel blockers to avoid this AV block. And the congener oxcarbazepine is also another good drug, and it can be used at I personally start at 150 milligrams twice a day, then escalated dose to up to 1200 milligrams per day. And the most common side effect is hyponatremia and Steven-Johnson syndrome. The other drugs we have, as Madam told, we have other drugs also, like baclofen, gabapentin, lamotrigine. Baclofen can be used up to 20 milligrams thrice a day, but I don't think so. Most of our patients tolerate this for at more than 30 milligrams per day. And gabapentin, we do use up to 300 milligram BD or 400 milligram BD, and not more than that our patients tolerate. And lamotrigine can also be used at a smaller dose slowly and can be titrated up to 200 milligrams per day. But the most important thing is we need to see the side effects of lamotrigine and be careful before starting the patient on lamotrigine. The other one is phenytoin, which we start at 50 milligram and go up to 300 milligram per day. And the routine side effects of phenytoin are routinely known. And the last one is pregabalin. We do start pregabalin at 75 milligrams per day and go up to 300 milligrams per day. Few patients do tolerate up to 300 milligram, but most of the patients don't tolerate more than 150 milligram. But I use this as an add-on drug to carbamazepine or oxcarbazepine. And when I cannot use the other drugs, I do start on pregabalin and find it more useful when we use in combination. So these are the side effects which are caused by carbamazepine and oxcarbazepine. And sometimes botulinum toxin is also effective in the treatment of trigeminal neuralgia. The only problem is we need to give it now and then, every 3 to 6 months, depending upon the patient's response, to alleviate the pain. Thank you. If patient is not able to tolerate medical management, yes, we immediately refer to neurosurgeon for further management. Over to Sridevi ma'am. Thank you.
It was a very complete evaluation of the medical management. Dr. Kritika, you would like to give any comment? Comments from you?
Yeah. Like she said, baclofen is a very useful drug, but high doses, many of our patients don't tolerate, and the muscle relaxation that occurs in other muscles interferes with the utility. And strangely enough, there are a few patients who do very well with phenytoin. It's an old drug, but there are a few patients who get quite comfortable with phenytoin. And that's like it happened with a case last week on seizures. They were trying all the newer anti-epileptics, but actually after they asked my opinion, we put him on valproate, and the non-convulsive status settled. So sometimes we discount the older drugs in favor of the newer ones. In my opinion, pregabalin doesn't really help much in many neuralgias. It just makes the patient very groggy. So carbamazepine, of course, and we are able to go to little higher doses with the oxcarbazepine, but we have the side effects of drowsiness and those elements. But I think the one thing I wanted to mention is that baclofen is a good choice, and phenytoin can be tried in some patients.
Thank you, Devi. She's MBBS from Bharatiya University, Coimbatore. General Surgery from Coimbatore Medical College in 1998. M.Ch Neurosurgery from Institute of Neurology, Madras Medical College, 2001. Memberships are multiple. She's at present a consultant surgeon in Royal Care Super Speciality Hospital in Coimbatore from 2016 onwards. She's going to talk to us about the balloon compression of the trigeminal neuralgia for treatment as the trigeminal neuralgia. Thank you. Dr. Sridevi.
Swarna Rekha is presently the Associate Professor, Kilpauk Medical College and the Government Rajaji Hospital, Chennai.
Government Roypeta Hospital, no?
Rayapeta Hospital, Chennai. And current position is Associate Professor in Government Rayapeta Hospital, Chennai. Senior Consultant, Dr. Mehta Hospital, Vedappan Chavadi, Chennai. She is a member of associations of NSI, TANS, Chennai Neuro Association, WINS, ANS, Tawins, etc. Publications published the original article in various international and national journals like Indian Journal of Research, IJSR, and International Journal of Neurology and Neurosurgery. Paper presentation presented e-poster and co-author in the e-poster Asian Australasian Congress of Neurological Surgeons meet held at Nagoya, Japan on 19th November 2007. Paper presented in 5 NSI conferences and as a co-author paper presented in various neurosurgical conferences. Areas of interest: teaching postgraduate in neurosurgery and conducting teaching programs like CMEs and conferences, neurointervention, minimally invasive neurosurgery, epilepsy surgery, neurocognitive rehabilitation. Now we invite Dr. Swarna Rekha Madam to give her lecture.
Yes, sir. Thank you so much for the introduction, sir. Are you able to see my screen, sir?
Yes.
Yes, madam.
Good evening to all my seniors and colleagues and friends. I'm very happy to join this precious meeting. Here I go with my experience and the microvascular decompression for trigeminal neuralgia. It's a very superficial talk about the microvascular decompression. It's not very in deep for like neurosurgeons, for common. And a few points for the postgraduates also. So, yeah. So, hyperactive dysfunction syndrome, HDS, this is a new terminology, a pathological condition caused by vascular compression at the root entry or exit zone of the cranial nerves is designated as hyperactive dysfunction syndrome of the cranial nerves, like trigeminal neuralgia, hemifacial spasm, genicular neuralgia, paroxysmal positional vertigo, and glossopharyngeal neuralgia. So, what is trigeminal neuralgia? Actually, a madam has already spoken in detail about it. I'll just give a small introduction like this. Trigeminal neuralgia is a pain which occurs in the face, typically unilateral, episodic, severe, stabbing, shock-like or lancinating, and exacerbated by cutaneous stimuli such as tactile pressure, chewing, brushing, breeze of air, shaving, and usually confined to one or more divisions of the trigeminal nerve. This is the definition. So, usually there will be a neurovascular conflict like this shown in the MRI. This is the intraoperative diagram actually. So actually my hard disk has crashed, so I couldn't able to bring about my original images. So this is the root entry zone of the trigeminal nerve where the vascular compression occurs. The root entry zone comprises the transition zone from central myelin, that is oligodendrocytes, to peripheral myelin, Schwann cells. This transition zone measures approximately 2 millimeters long and is situated at approximately 5 to 7 millimeters from the surface of the pons. That is the transition zone. Pathogenesis, the site of the neurovascular conflict is typically at the root entry zone of the fifth nerve. as it enters the brainstem and usually not along the nerve in the CP angle cisterns, although the certain myelin may extend distally along the nerve also. Whether neurovascular conflict in MRI is mandatory? No, but the patient should have classical trigeminal neuralgia symptoms and purely paroxysmal pain. So these are some prominent landmarks in history. In 1992, Dandy, he stated that vascular compression might be the cause. And Gardner and Sava, they operated for hemifacial spasm and TGN. But MVD, the name Microvascular Decompression, was devised by Janetta without sacrificing neural integrity in 1966. Although Dandy and Gardner have done MVD for trigeminal neuralgia, the affected nerve was sectioned partially or completely prior to Janetta's MVD era. So MVD is the procedure of choice for healthy and relatively young patients, younger than 70 years. So who are all the surgical candidates for MVD? After ruling out all the below causes and the causes which Dr. Aruna madam was enumerating, demyelinating disease, infection, inflammatory process, vascular malformation, and neoplasms. After ruling out all these things, patients who have refractory classical trigeminal neuralgia and even after the drugs and showing neurovascular conflict will qualify as candidates for MVD surgery if no other underlying etiology is found. So what are the benefits and drawbacks? The benefits are it is non-destructive. There is no numbness or dysthesis. It's curative. The drawbacks are requires general anesthesia. The craniotomy is required. Due to the craniotomy procedure, increased risk of lethal complications, not advisable for older patients. So what needs to be done in MVD? We need to reorient the vascular loop, which is causing the compression at root entry zone. How effective is MVD for trigeminal neuralgia? 95% effective with relatively low risk of pain recurrence, with little or no numbness. So these are the anesthetic considerations. Under controlled ventilation, with the CVP catheter to manage air embolism in case we are operating in sitting position. So this is the aim of the microvascular decompression. The aim is to reorient the vessel which is causing the compression, transposing the fat, muscle, Teflon, Dacron, gel foam, etc. in between the trigeminal nerve root entry zone and the vasculature which is compressing it. So coming to the steps, this is for postgraduate a few points. Okay, so this surgery can be done with the patient in sitting position or in lateral decipitous position. In sitting position, this gives no pooling of CSF or blood. There is no chest compression. But only problem is air embolism. In lateral decipitous, there will be pooling of CSF, but it has less chances of air embolism. So the choice is by the surgeon. So this is a skin incision. It's a retromastoid supracerebellar approach. The line of incision is approximately 8 centimeters behind the ears. Craniotomy or craniectomy about 3 into 3.5 centimeter is made just posterior to the mastoid notch, transverse sinus superiorly and sigmoid sinus laterally as margins. This is a margin. This is a sigmoid sinus here. It's a transverse sinus here. And if mastoid hair cells are open, that need to be waxed, or else a patient will have persistent CSF leak. This step is very, very crucial. Dura opened in L-shaped manner, care should be taken not to injure transverse or sigmoid sinus. So after opening the dura, you'll be able to, after you gently retract the cerebellum over the superior surface, the CSF, after the CSF drainage, the anatomy of the fifth cranial nerve and root entry zone will be visible. At this point, the petrosal vein need to be identified and if needed, coagulated. With the sharp dissection of arachnoid around fifth nerve, we have to dissect only around the fifth nerve, not over the seventh or eighth nerve. The vascular loop can be dissected out from the compression and the Teflon or muscle can be kept in between them. Complete inspection of the entire circumference of trigeminal nerve around the root entry zone is mandatory. This is the root entry zone. Around this root entry zone is mandatory. Around your entire nerve we have to look into. So positioning the Teflon between the root entry zone and vascular loop. Few technical points for the postgraduates. Most common artery is the superior cerebellar artery. The most common vessel is artery, and in the superior cerebellar artery is the most common. While retracting the cerebellum carefully, look for the petrosal vein. Detether the organoid at the apex of the vascular loop. In case of superior cerebellar artery, it should be elevated to a horizontal position rather than vertical and displace it upwards. In case if you are seeing the vessel compression from the inferior aspect, it must be displaced further inferiorly. Keep the shredded Teflon. Apart from keeping the Teflon as such, if you shred it and then keep it, it will lie in that position for nicely. It will maintain the vessels in position. If any vascular spasm is noted, the papaverine can be instilled on a gel foam and kept over the vessel. So, usually it's 80% of arterial compression, around 13% or venous compression. The causative vessel, 80% is superior cerebellar artery most of the time. In 9% of the people, it is SCA and ICA. 8% is ICA only. 2% is basilar artery. There are incidences where no causative vessel is identified at all intraoperatively. For those cases, the postoperative status of trigeminal neuralgia symptoms should be assessed and acted accordingly, whether to go for medical therapy or Gazerian ganglion injection or local infiltrations, or as N.Sridevi madam is going to present, that procedure is also can be tried. So what are the complications of this surgery? Facial numbness, 4th, 7th or 8th nerve palsies, cerebellar symptoms, disequilibrium, cerebellar infarction, brainstem infarct, CSF leak and bleed as it comes for all other procedures. So 80 to 90% of the patients have long-term pain relief of more than 10 years. This is the main outcome of MVD with respect to when comparing to the other procedures. So the take-home message is we can achieve long-term pain relief. Mostly it's curative. The positive predictor for outcome is classical trigeminal neuralgia and purely paroxysmal pain. The presence of neurovascular conflict in MRI is not mandatory for MVD surgery. But the positive predictor outcome, the classical trigeminal neuralgia symptom and pure paroxysmal pain is mandatory. So analysis of complications and surgical nuances for avoidance is essential. These are all the references. Thank you so much. Thank you.
Rekha.
Thank you, ma'am.
Thank you very much. Only one small comment. If you don't find a vessel, what do? You open all the arachnoid spaces. That's what you do. Thank you.
Sorry, it's not only that, madam. We can squeeze that sensory fibers so that we get the pain relief. That's the most important when we don't find any vessels. Obviously, we will find it, but if you don't, then at least we can do that and they will have a pain relief. Of course,
you can do a localized neurolysis.
Yes.
Yeah.
There may be some numbness, but still it worth it.
Yeah. Thank you.
Everyone. At the outset, first I would like to thank Dr. Rajesh Babu for giving us the opportunity to talk about the common, which is trigeminal neuralgia, which is the most common disease we often see in our clinics. And I would like to thank the moderators, Dr. Vijaya ma'am and Pritika Achari ma'am, for accepting to be the moderators, and our four speakers, Dr. Anna Devi and Dr. Rekha. The topics which we are going to talk is now on treatment options in trigeminal neuralgia. Already Dr. Anna Devi and Dr. Rekha have discussed elaborately about the symptoms and the investigations we are going to do. But it is only Recap. Trigeminal neuralgia is a short electric shock-like paroxysmal lancinating pain in the distribution of one or more branches of the trigeminal nerve on one side. It is always unilateral. Rarely it is bilateral. There are periods of remission when patient feels that they are cured of the disease, but it is not so. There will be recurrence and there will be initial response to carbamazepine. Neurological examination will be absolutely normal. Then only we consider it as idiopathic trigeminal neuralgia. If there are signs concerned with trigeminal neuralgia nerve, then we must think it as secondary cause of neuralgia. Like we have to rule out the tumors, AV malformations, multiple sclerosis, and other things. And 80 to 90% of the cases are caused by neurovascular compression at the trigeminal root entry zone. In patients with the multiple sclerosis, it may be due to multiple sclerotic plaque. 75% will ultimately fail medical therapy and require a procedure. And choice of therapy depends on the patient's age, location of the symptoms, and prior treatment. So when we are going to evaluate the patients with trigeminal neuralgia, even if we think that it is idiopathic trigeminal neuralgia, we have to do MRI brain to rule out neurovascular compression, intracranial tumors, and multiple sclerosis. And if we are planning to do an percutaneous trigeminal balloon compression, then we have to do a CT brain. It is a must because we have to check the foramen ovale size. The size of the foramen ovale should be always more than 5 mm in both anteroposterior and transverse dimensions. Options available are medical and surgical. Medical treatment has been already elaborated by Dr. Aruna. Surgical treatments, we choose surgical treatment when patients are refractory to medical treatment and in patients where side effects of the medications exceed the risk and drawbacks of surgery. Options in the surgical treatment are MVD. It is more physiological because we just separate the offending vessel from the root entry zone. So there is no alteration in the nerve function like sensory loss or motor weakness. But all the other procedures available are mostly ablative. Ablative procedures are percutaneous as well as peripheral procedures. In percutaneous procedures, we got percutaneous trigeminal balloon ganglia, Assyrian ganglion compression, and radiofrequency lesioning, glycerol injection. And the stereotactic radiosurgery, where we give high dose of radiation focused to the trigeminal nerve, thereby blocking the sensations going to the brain. And deep brain stimulation, which is not commonly practiced. And deep brain stimulation is mostly useful for post-herpetic neuralgia and trigeminal neuropathy and other things. Peripheral procedures are nerve blocks and neurectomies. When we compare the percutaneous techniques, radiofrequency is like we apply low frequency current over the involved trigeminal divisions like V1, V2, V3, where anesthesia may be required. And in radiofrequency listening, dysesthesia is more compared to other ablative procedures like glycerol injection and balloon compressions. In glycerol injection, alcohol damages the nerve fibers in the system and it is non-selective mostly and no anesthesia is required. In radiofrequency, we can select the division whichever is involved and give the pain relief. And balloon compression, inflated balloon compresses the nerve fibers and the ganglion in the system. It may be selective. Most of the time it is non-selective. It requires general anesthesia and dysesthesia is very less when compared to radiofrequency and glycerol injections. Percutaneous ganglion balloon compression is, how does it work? It compresses the thick myelinated fibers, which are the trigger fibers to the pain by aphatic type contact with the nociceptive fibers A, delta, and C fibers, leaving the thin and unmyelinated fibers unharmed, A, alpha, and beta fibers. So when do we do PTBC? Indications are when patients who are at poor risk for general anesthesia, elderly people who are high risk for giving general anesthesia to undergo a major procedure, opening the skull. And patients, even if they are younger, who wish to avoid major surgery can be taken up for PTBC, and who have patients who have unresectable intracranial tumors, and in patients with multiple sclerosis, and the patients who have limited life expectancy, but the pain is intolerable, they have to undergo some procedure. This minor procedure they can undergo. And when other procedures have failed, like sometimes even MVD fails and radio frequency listening fails. So in that cases, we can always go ahead with the PTBC. History of balloon compression. In 1954, Sheldon and Prudence concluded that patients with trigeminal neuralgia treated by decompression and compression of the peripheral branches in the oval and round foramen with a subtemporal approach had better results than decompression of the posterior root of the retrogastrian section. These investigators concluded that compression of the trigeminal fibers during the operation was the prime factor that allowed for the pain relief associated with decompression procedures. Finally, in 1983, Mullen described the actual technique of percutaneous balloon compression of the ganglion through the foramen ovale. So the procedure which we follow now is the Mullen's technique. So how do we do the procedure? Patient is positioned supine and the instruments required are 14 gauge needle, 4 French balloon catheter, CM image intensifier, ECG monitor, defibrillator, and non-ionic water-soluble contrast. Patient should take antiseptic mouthwash a day prior to the surgery. Anesthesia, general anesthesia, endotracheal tubes. When the anesthetist intubate the patient, the tube should be positioned like this. The endotracheal tube should be curved downwards in the midline. Needle insertion, we mark the point like this. We might mark 3 points actually. One is 2.5 centimeter. 2.5 centimeter from the lateral angle of the mouth, and another one is the mid-pupillary line, and third point is 2.25 centimeter in front of the tragus. Step 1, first we pass the needle. We pass the needle in the point 2.5 centimeter lateral to the angle of the mouth, and 2 millimeter above is the entry point. So we infiltrate the saline along the needle track. Then pass the 14 gauge needle along the track. CM imaging is done in the lateral skull screening. Needle is directed 2 centimeter below the dorsum cellae in the clival line. So the needle tip should be in the clival line 2 centimeter below the dorsum cellae. Needle entry, when the needle enters the foramen ovale, the patient will have bradycardia. So we can so once patient gets bradycardia, we are sure that we are in the foramen ovale, then engage the needle at the foramen ovale. Then once the needle is engaged in the foramen ovale, withdraw the stellate, pass the balloon catheter beyond the needle tip to enter into the Meckel's cave. Then inflate the balloon with 0.75 ml of iohexol and do the screening. Then inflate the balloon and the tip should be beyond the porous trigeminus. And when we inflate the balloon, a pear shape occurs and the pressure goes beyond 900 millimeters of mercury within the balloon. And maintain this pressure for about 10 minutes. Then after 10 minutes, deflate the balloon, remove the catheter, check the balloon tip for the intactness, and then remove the needle. Then apply cheek pressure because we are using 14 gauge needle. Patient will have some amount of cheek hematoma, so we have to apply cheek pressure for some time. These are the instruments required, and 14 gauge needle is passed, and the foramen ovale is entered. Then pass the balloon catheter, check the balloon, then pass the balloon catheter into the needle, then inflate the balloon, and the balloon shape should not be like this. The balloon shape, if we get the shape like this, then deflate the balloon and adjust the balloon and try again till you get the typical pear shape.
Why are you touching?
Okay, leave it.
Yes. Yes.
This is the typical pear shape. And we get this teeth. And when balloon is inflated, patient will have bradycardia. Advantages of PT-BCR: low incidence of complications, minimal invasiveness, results are immediate. Pain relief is immediate. Once the patient recovers from anesthesia, will have pain relief, and high proportion of pain-free patients after the procedure. It is very advantageous in elderly patients. It can be repeated several times if symptoms recur or persist. Complications are balloon rupture, cheek hematoma, occipital headache due to dural stretch, hypoesthesia in all three divisions, and corneal sensory blunting, trigeminal motor weakness, which is temporary, and meningitis and subdural hematoma are the rarest complications. Observations for the treatment: an accurate diagnosis is essential. Diagnosis is made by history because there are no signs to elicit. Be optimistic, caring, and a good listener. There is no best procedure available for trigeminal neuralgia. If the pain is not relieved by any one procedure, we have to do many procedures. Treatment should be individualized. Medication should be tried first. Dysesthesia may occur with all the ablative procedures. Dysesthesia is not responsive to additional ablative procedures. Outcome of the treatment worsens with chronicity. The longer the duration of the pain, the patient lesser the pain relief. Conclusion: the trigeminal neuralgia is a painful condition. Although there are multiple surgical approaches available for treatment, percutaneous balloon compression is the best alternative treatment option that offers high effectiveness, low morbidity, and less hospital stay.
Can I say something?
Yes,
Another
Yes,
treatment
madam.
choice. Another treatment choice today is transcranial magnetic stimulation, which is being tried and found quite effective in patients who cannot be operated or who are not getting relief with medication. It definitely reduces the pain. And of course, it's an expensive specialized equipment. But TMS is being tried in many, many indications, including stroke and various other Parkinson's and things like that. But it's also being useful in trigeminal neuralgia.
Okay.
Sridevi madam. Madam, you told in the beginning of your talk that these kind of treatment like balloon compression and all is for the patient who is very much elderly, not undergoing for anesthesia, general anesthesia. But your procedure is general anesthesia.
It is done under general anesthesia, but it is less compared to the suboccipital craniectomy and doing the microvascular decompression near the brainstem. So patients who are unfit, like comorbid conditions with diabetes, cardiac problems and all, cannot undergo prolonged general anesthesia. For them, it is very useful because it is a very short period. We can finish up the procedures.
Is it in another word, is it be done under local anesthesia also? Or any center is doing so?
It is not possible in local anesthesia because that 14 gauge needle is a really bigger size. So patient need to have a general anesthesia. Even sedation is not possible. IV sedation.
Madam was asking about the timing. Dr. Vijaya madam is asking about timing.
How
How
long does
can
it take this procedure?
Madam, if the foramen ovale size is of adequate size and in one pass, if we go into the foramen ovale, procedure will be over in half an hour time. But sometimes, it's very difficult to get into the foramen ovale. So in that time, it takes time, maybe 1.5 hours also it takes.
So normally, MVD can be done in 1 to 1.5 hours time, but obviously it is minimally invasive. I agree.
But when you describe the procedure and the risk to the patients, they often ask for the less invasive procedure than the major procedure like craniotomies.
That's true. Many patients do not
Yeah.
accept.
I always offer them the options, MVD and balloon. Most of them only choose the balloon compression than the MVD.
It is like when you offer both clipping or endovascular procedure, they take endovascular only.
Yes.
Only thing, which one is best is the thing, which unfortunately as a surgeons we are unable to, what is it, not convince, we can't tell the patient properly. That's the problem. They will take only the so-called minimally invasive. That's
No,
the thing.
I have done procedure balloon compression even after failure of MVD.
Yeah, that's true. That's true. Even all the procedures are complementary actually.
Yes,
When
so
there is what is that failure in MVD, I used to send for either whatever the percutaneous methods that may give them a confidence initially, and finally they will come for MVD after 3 months or 6 months. That's a different matter. That is true.
So we have to tell
swears by glycerol.
positives. We have to tell the patient positives and negatives so that they choose the treatment, not us, so that they don't find fault with us even if failure occurs.
Now, all the speakers did very well in their presentation. So Dr. Sonaraga nicely put out the procedures of the MVD. Of course, if you would have given some your own video, it would be very nice. At least other videos. It's of course it's
problem is my hard disk crashed. Like that's why I couldn't. I lost so many videos and pictures of all my cases I have done before. I lost almost everything.
But it's good. Your presentation is very good for the surgical management. It's nice.
Thank you, sir.
Madam, as usual, Dr. Aruna Madam has mentioned all about the medical management and the trigeminal neuralgia. It's an eye-opener. Most of the neurologists won't send for the MVD, but now it has changed because I think all the neurosurgeons are showing their good results to them, so that people are not hesitant nowadays to refer to MVD. Leave alone the percutaneous methods. Most of the people send the patients to surgeon at the earliest possible time. Yes, Dr. N.Sridevi Madam says if we give all the options, patient can choose. And of course, most of the patients choosing the MVD. That's a good thing.
Sridevi?
Yes, ma'am.
On an average, how many people come for balloon compression? Every month?
In winter, lots of patients come. At least 2-3 patients per month we see, madam. And in summer, it's very less. Because it is mostly in winter, patients who get this aggravation of the trigeminal pain. So in winter season, many patients come, we do see. At least 2 cases per month we'll be doing in winter seasons.
I think Dr. Kodiswaran, our treasurer of TANS, is here.
Yes.
Who is doing a high number of percutaneous injections at Kilpauk Medical College. If you have any comment,
He swears by glycerol.
Dr. Kodiswaran is there?
Good evening, everyone. It was a wonderful session, madam. Actually, balloon compression, it was totally new to me. We were not doing that. Actually, in Kilpauk Medical College, almost we are doing percutaneous glycerol rhizotomy in large numbers. So we have 2 group of patients. In the last 3 months, we have done almost 30 patients. After our workshop, the news was published in paper. So a lot of patients are coming from all over the state. So our series has crossed more than 250.
Wow.
So compared to microvascular decompression, nowadays I'm not doing any microvascular decompression. And also we have 2 group of patients. One is failed trigeminal neuralgia and first time procedure for percutaneous glycerol rhizotomy. So in failed group, almost we have crossed 30 patients. So actually in large number we are doing, our failure rate is only less than 3 to 4%. So for example, if you are doing 10 patients, very few patients only getting failures because of technical problem. Once you reach the foramen correctly, most of the patients are getting pain relief. That too, as projected in literature, it was not a very bad ablative procedure, because nowadays I have increased my glycerol dosage also. Previously, as per literature, it was mentioned as 0.75 ml. Nowadays, I am giving up to 1 to 1.25 ml, depends upon the patient's symptoms. Most of the patients are getting very good pain relief if the technique is done properly. And also, I use only lateral view. I won't do in AP view. That too, we have few methods for our technique. So according to me, we are trying to publish the data in course of time to prove that glycerol is one of the main treatment of choice for trigeminal neuralgia.
Actually, you don't give general anesthesia, isn't it?
It's done in local, madam. It's done in 10 minutes. So very less risky procedure. And also it doesn't require any craniotomy. And also very less expensive too. That too covered in government health insurance scheme. So we are doing all patients free of cost in our hospital.
Actually, Dr. Cody is advertised as a daycare procedure.
Yes,
so
madam.
People are very happy about it.
Yes, madam. So we don't have experience in balloon compression. So we didn't try it yet. So that's why I was listening Sridevi madam's lecture, and also Dr. Vishwanathan is doing balloon compression in Chennai in Ramchandra Hospital. So in our workshop and conference, we have called all the people who are doing in different techniques. Actually, Vijay madam also came to that workshop. And also we did, because the problem in glycerol injection is, it is technically highly demanding. It needs a lot of expertise, and also the failure rate because of only technical difficulty. The reaching the foramen is a difficult job compared to other procedures. Once you learn it, it is one of the best procedure according to my experience. So nowadays we are going to do randomization also, but it's very difficult to randomize the patients for surgery, and also because two people should do the different techniques. So in course of time, we are trying to get the literature data to compare our results in MVD, glycerol, radio frequency, and also percutaneous balloon compression. Already we have published 2 papers. One is in glycerol rhizotomy in 2015. That time our series was almost 100. And also we have published another data in 2019 for failed procedure. Any procedure, we are doing only glycerol. That time we published for 19 patients. So now almost our series comes around 280, including failed procedures.
Yeah, I just want to add that if the trigeminal neuralgia is secondary to multiple sclerosis, MVD also sometimes gives very, very poor results. It may give temporary pain relief for maybe a year or so, but it does not help patients with multiple sclerosis. Most of these procedures don't help such patients.
No procedure, even glycerol injection.
None of them work for too long because the primary lesion is there.
Yeah, okay, that's it.
So we don't really get rid of the primary. When we treat the MS itself with specific drugs, immunomodulatory drugs, sometimes they settle down. The severity of the pain comes down. They feel a little more comfortable. But it's a very difficult refractory kind of trigeminal neuralgia if they have a lesion which is causing it.
Actually, madam, one of the main contraindication for MVD or other percutaneous procedure is multiple sclerosis.
Yeah, but there are some people who are doing it. I have had a few patients where some people have attempted it. And it really is not worth so much opening the skull and or doing a craniotomy and all that, or when the patient has already got other issues. The MS itself is a big enough burden.
Yes.
I like to request Dr. Suresh Jayabalan to tell his experience about management of the trigeminal neuralgia. What is his experience about totally how many cases of the surgery he might have done? He can tell in brief about it, sir. I request him to give his views.
Thank you, Rajesh Babu. Yeah, obviously we have all discussed about that so far, but to my present practice, I don't do any percutaneous procedures nowadays. For a simple reason that I used to tell the patients that if there is a reason, we have to deal with that reason. Here we know from Professor Janata that there is a reason, that is the vessel is compressing on it. There is no point in giving an injection or a balloon compression or a glycerol rhizotomy, all those things, because all those things are ablative procedure. Even though nowadays we claim, like Dr. Kodison claims, that it is not that much of ablative, but it is ablative. So wherever possible, I tell the family that we treat the causative thing, like MVD. In my experience, I have done 86 years old gentleman also. So age is not the bar. Except, of course, we have to think about their comorbidity. Nowadays, when we say that it's elderly person, now we just change that word. I don't think Dr. Prithika Acharya or Dr. Vijay will accept that 60 or 70 as an elderly. Because I experienced it when I joined Coimbatore in that corporate setup, when one of our professor, our chairman used to tell, why you are operating under 60 years, 70 years. Now he won't say because he is 87. So it's like that. So it's elderly is a different category. We can't take it. So the eldest person was 86. So far they are doing well. Of course, comorbidity is a very important thing. They have to withstand that surgical trauma. Of course, we have a lot of armamentarium to withstand all those things. But still, that's one other thing. I used to tell the family that I cannot change the age, but we try to treat. That's what we do. Failures are there. It is not that without any failure. Even the next day, I used to take that patient to the theater. We found the vessel and we have done the microvascular decompression for that vessel. So the thing is, I have stopped doing percutaneous for the last 10 to 12 years. Only MVD. Results are good. We have our own share of complications like CSF or sometimes the recurrence. So for 2 patients, I have taken the next day itself. Family agreed because they know we have to tell them properly. But now, as Kodis and Sridhar madam says, the percutaneous procedures are coming up in a more, refined way. My patients like elderly patient with recurrence, that elderly patient for the first time. I'll give them a choice and I'll tell them that MVD is the best. So most of the patients used to come for MVD. We have a good result. But of course, as I told you, we have a recurrence which went for the surgery on the next day, 2 patients. 3 patients after 2 to 3 months. And almost 3 patients I have sent for percutaneous. So far, in my case, I have more than 100 so far. But this is my experience. Percutaneous worked them well. To be frank, around 80 plus patients after MVD, they come after 3 years of recurrence, 3 years later recurrence. I don't want to operate on them on 83 years or 84 years for recurrence. So sent for percutaneous, it's worked well. They came back and thanked me. That's the main thing. Of course, you didn't ask for a surgery. So as a neurosurgeon, as I already mentioned, most of the neurologists are referring to us. And it is our thing which one to choose. Of course, family will choose, but we have to guide them. And still MVD is a gold standard. Percutaneous is with more refinement, of course, we can do. But first choice is MVD, that's what I feel. Maybe the others may have a difference of opinion. Thank you.
There was a question by Dr. Shyamala. Did you see it?
Madam,
Ian asked whether PRP can be used. I've never. Cody?
Madam?
PRP, platelet-rich plasma.
Man, I don't have any idea, madam. I don't have any idea.
I don't think I haven't read it anywhere.
PRP means infusion or I don't know what kind of
So maybe in the Cassidian gang.
Oh.
No, I
Madam
don't
Shyamla
think
madam is there.
Yeah,
it
she's
has any
there.
role.
Madam, you can
Infusion,
ask
he
the
says.
question, madam.
He says infusion. Ask her to talk to us.
Ma'am, good evening, ma'am.
Tell us.
Yes,
Yes,
madam,
madam.
you can talk.
This is Dr. Shamla.
Your
Ma'am.
doubt.
Ma'am, I recently read in one journal that platelet-rich plasma therapy can also be, like infusion can be injected into the Caesarean ganglion. So I just wanted to know whether we are using it right now.
Can you please introduce yourself, Dr. Shyamla? Is it our Shyamla madam or somebody else? Just we wanted to know.
Sir,
This
this
is
is
Shyamla
Dr.
madam only.
Shamla. Yes, sir.
No, Professor Shyamla madam da.
Madam, then, I don't know, madam. I have no experience.
That's okay, sir. Fine.
There was this article.
Odiswaran sir, do you have any idea of doing the
No,
injections
no,
like
sir.
that?
No, sir. No, sir. I don't have any idea. And I want
No,
to
in
say my
future, are you
experience.
going to try that?
No, sir. No, sir. I'm very comfortable with glycerol. Because I want to say another point. My longest follow-up is 14 years and 6 months. So one patient, single injection, is doing fine for more than 14 years. And according to me, as projected in literature, glycerol is not a very bad injection. Like everyone is saying, it's an ablative procedure. It will produce a lot of dysesthetic pain. The major issue in glycerol, what I experience is, if you are doing for failure patients, patients are developing numbness. So whenever I do a failure patient, I used to tell them, you will develop numbness. So most of them are accepting it. Compared to their pain, they are accepting the numbness. So in first injection, it is not producing any numbness. So we have a lot of gradings and follow-up scores. So we are collecting all the data for the past 14, 15 years. So according to me, it is not producing any dysesthetic pain also. In failure patients, numbness is one of the important complication because already it was dealt with some other treatment. Even glycerol also, we are injecting again, patients are developing numbness.
Now we will have the answers and the winners.
Sir?
Naveen, you put the answers, sir. So for the question one, how many nuclei are present in the fifth nerve? Answer is 4. The winner is Dr. Raghu. Dr. Raghu is available here.
One minute,
Dr. Raghu.
Babuji, just a minute. Please put the answer also, not the 4. That's good that everybody can know how many nuclei are there. Is it possible? Or at least you can tell.
I think Aruna Devi had that.
Yeah, madam can tell, but with the answer, please.
The madam is not available.
Aruna Devi madam left actually.
Okay, somebody to tell.
The spinal motor sensory and Jeff nucleus.
Okay, like that, please. Right.
So the winner is Dr. Raghu. Dr. Raghu is there.
Sir, good evening, sir.
You are from which institute, sir?
Sir, I am working in Surrey GH, sir. Assistant surgeon from the general medicine, sir. Assistant surgeon, Surrey GH, sir. Trichy district. Hello, sir. Am I audible, sir?
Yes, sir.
I am working as an assistant surgeon, sir, in Surrey district, sir. Trichy district, Surrey, sir.
Surrey district. Government hospital.
Government hospital.
Yes,
sir.
Congratulations. Congratulations. Your specialty?
Thank you, sir. General medicine, sir.
Huh?
General medicine.
General
Oh, very
medicine.
nice. Physician. Very great. Excellent.
Thank you, sir.
Thank you for joining the program. Second
Thank you, sir.
question.
Thank you.
Second question. Is the trigeminal neural nerve purely sensory? No. The winner is Dr. Praveen. Dr. Praveen is available here. Dr. Praveen.
Yes, sir. Yes, sir.
You are from which institute, sir?
Tirunelveli Medical College, sir.
Huh?
Tirunelveli Medical College.
What are you doing? Tirunelveli Medical College.
Sir, Neurosurgery PG, sir.
Wow.
Oh, congratulations. Congratulations. Which year?
Now second year, sir.
Already associate member of TANS.
Yes, sir. Sir, given application.
TANS member ஆயிட்டீங்களா?
இல்ல application கொடுத்திருக்கோம்.
நவீன் மெம்பர் ஆக்கலையா உங்களை?
Sir, approach. Sir, வாங்கியிருக்கேன் sir. Forms வாங்கியிருக்கேன்
எல்லாரும்
sir.
மெம்பர் ஆயிருங்க சீக்கிரமா.
Yes, sir.
Okay. Question number 3. How is the pain in the trigeminal neuralgia typically described? Lancinating pain. Winner is Dr. Nagavishnu Sankar. Nagavishnu Sankar.
Good evening, sir.
Yes, welcome. Congratulations.
Thank you, sir.
You wanted to ask something, no? You asked the question now.
Sir, how much time will it take for the patient to respond to medication, sir? Generally, patient ask how much time will it take for this carbamazepine or oxcarbamazepine for trigeminal neuralgia we are giving you, sir. So usually, how much time will it take for the patients for response of the symptoms, and how long can we wait, and how much duration? When can we say that it is refractory to medication and we can go for a surgical and other options, sir?
Yeah, actually, Vishnu, it's a very good question. Actually, one of the, maybe we take it as a diagnostic criteria is for a trigeminal neurologist, if it responds to carbamazepine. We take it as a diagnostic, as a clinician. So it will respond immediately in the first instance. But the problem is it won't respond in a long run. We have to increase the doses. We don't know. Each person, each patient is different. Some people may go for 2 years or 3 years, or some people may not respond within 2 to 3 months. So we have to increase the doses of carbamazepine. Then we add on the medication. We add the medication so that they will get better. But unfortunately, what happens is if you add the medication dose or add on the other drugs, patient will feel more drowsy. That is the thing, patient comes for the other alternative. But it is not that the pain alone. Pain is there, it is refractory. It is like each person is different. For example, if I have a pain, even 2 or 3, it will be very difficult for me to bear because we have to work hard. For example, one very important person having a pain means they cannot do that. But others, they may just go on along with the pain. The refractory is just arbitrary. So what happens is you give more medications with higher doses, patient will be more sleepy and it's not working for them, the pain comes. Then we call it as refractory. Then we or the neurologist will suggest for the other treatment option like a invasive procedure. Whether you go for a percutaneous or a MVD, it's all depends on the patient. That's what. It's nothing called that such a duration, all those things. Like Dr. I think Dr. Aruna madam told 3 drugs or 3 times per day, all those things. It is there in a literature, but it's arbitrary. You see, it's like a refractory epilepsy. Whenever it affects your function, it's called refractory. As simple as that.
Okay. Thank you, sir.
Madam can put some light on it. Dr. Vijaya madam.
Same, sir. With medication, the same way you said. There is no time. Maybe it will take 10 days, maybe it will take 3 months before they respond to it. But as you said, if it goes on for 2 years, it keeps on increasing. The dosage keeps on increasing. That is how they land up with us. That's what about the next
question and answer? Next, Sridevi madam's questions. Question 1. Which is the minimum size of the foramen ovale? More than 5 millimeter. The winner is Dr. Raghu. Dr. Raghu, once again, congratulations,
again,
Dr.
he's
Raghu.
Okay.
Thank you, sir.
Once again, Dr. Raghu. Then the question number 2, which is the ideal shape of inflated balloon? Pear shape with the teeth is the answer. And the winner is, once again, Nagavishnu Shankar from Tirunelveli. Congratulations, Nagavishnu Shankar.
Thank you, sir.
Then questions from Swarna Rekha Madam Stock. Which of the following symptom is not a recognized feature of classical trigeminal neuralgia? The pain occurs in junction with facial flushing. The winner is Dr. Raghu once again. Dr. Raghu.
Thank you, sir.
Congratulations, Dr. Raghu. Dr. Raghu has won
Thank you,
3
sir.
questions today. And last question, which of the following medicine used to treat trigeminal neuralgia is currently considered first choice therapy? Carbamazepine. And once again, the winner is Dr. Nagavishnu Shankar. So Nagavishnu Shankar has won 3 questions, and Dr. Raghu has won 3 questions, and Dr. Praveen has won 1 question. So congratulations, all the winners. I like to ask one question from the panelists. What about the experience of eslicarbazine? Anyone has tried eslicarbazine for trigeminal neuralgia? I like to know about it, because they are telling eslicarbazine the complications are less. That's why.
Yes,
Any experience?
Yes, we have tried in patients who have recurrence of pain post balloon compression, and they respond well.
What is the dose you have used?
Actually, 800 milligram. We use it as 400 milligram BID dosage.
It shows good improvement.
I also have a question for Dr. Aruna Madam. Is he here? Aruna Madam? Yes,
Madam has gone.
Madam
No, sir. Madam left, sir.
Okay. When we were studying carbamazepine, maybe the drug of choice, I thought now it is also carbamazepine, but it's not so. Vijay Madam, Dr. Sridevi.
No, what they are saying is eslicarbazine, the complications of hyponatremia is not there, it seems. That's what they are trying to come out. The eslicarbazine they are telling. The hyponatremia complication is not there, it seems. That's what they are telling. That's why can we try that in future also like that? That is the question arising here.
But when we start the patient on eslicarbazine, in the prior to any of the treatments, they don't respond. Post procedure response is good. First choice is only oxcarbazepine.
Okay, any other questions, any other discussions? Anyone want to tell anything? Yes, Madam, Vijaya Madam, you can. Kodiswaran sir, you want to tell us anything?
No, sir, no, sir. It was a wonderful session. That is my final point.
The question I am just repeating. What do you start, whether the carbamazepine or oxcarbazepine? Sridevi Madam told oxcarbazepine. Even I feel we start
Carbamazepine is the
oxcarbazepine.
best drug, sir. For actually, according to me, carbamazepine is working good. But nowadays, I don't use carbamazepine. I use only gabapentin and tapentadol.
Okay.
Okay.
So this combination works very well. That too, it is not addictive. So you can use in daytime. For example, I used to give morning dose of extended release of tapentadol. So patient will not become drowsy in daytime. So in evening time, I used to give gabapentin. So they'll sleep nicely. This combination works very well. So I don't use carbamazepine nowadays because the patients are coming to me are treated more than 5 years, 8 years, 10 years with carbamazepine. Once you stop that carbamazepine dose, they are very comfortable.
Yeah.
Then slowly, the drowsiness, that for example, that day-to-day life is already very miserable. So first my treatment is I'll stop carbamazepine.
Thank you, Rajesh. Jaypalan, thank you very much.
Thank you.
It was a very nice program. Sridevi, we must
Thank you,
give her kudos for bringing us all together.
Thank you, thank you.
Now I request Dr. Kodiswaran sir to give vote of thanks.
Thank you, sir. Dr. Rajesh sir, his excellent efforts to continuing this CMEs were wonderful. All for the lecturers and also the participants on behalf of Office Bearers of TANS. So thank you for joining us and good night. So we'll see you in next continuous TANS CME program.
Thank you.
Thank you, one and all.
Thank you all. Thank you all. Good night.
Thank you, Jim. Thank you, Rajesh. Thank you, Dr. Suresh.